Hi, we're gonna get started now as people start joining. My name's Melissa Gans. I'm assistant professor of pediatrics at University of Miami and Jackson Memorial Hospital. As some people join, before I introduce everyone, I just want to give a plug for the annual meeting for Clinical Immunology Society. That's March 31st to April 3rd in North Carolina. The registration deadline for in person is coming up on March 2nd, so make sure that you register by then. I'll be there, and I hope to see a lot of you there as well. So for our first presentation, our presenter is Dr. Shreena Desai, who is an internal medicine resident at the University of Miami and Jackson Memorial Hospital. She's applying for Allergy and Immunology Fellowship this upcoming cycle. And she's going to be presenting multisystem inflammatory syndrome in a toddler with underlying inborn error of immunity. And we're very lucky to have Dr. Rebecca Marsh from the University of Cincinnati as our senior mentor today. So Trina, I'll leave it to you.
All right. Good evening, everyone, and thank you for joining in. I'm honored to present to you an interesting case of multisystem inflammatory syndrome in a toddler with underlying inborn error of immunity from our institution here at the University of Miami. Thank you to my mentor and moderator, Dr. Melissa Gans, and senior mentor, Dr. Rebecca Marsh. So I have no disclosures to reveal. And we'll get started. So our patient is a baby boy who at 4 months of age developed streaks of blood in his stool, which persisted despite multiple changes in formula. The streaks of blood in the stool were initially thought to be due to an allergic cause, so he was switched to a special formula. However, it continued to progress to blood clots around 7 months of age and was also associated with abdominal pain. At that time, he was switched to Elecare formula and the bleeding improved. But then 1 month later, he had more blood clots, this time associated with fever, vomiting, diarrhea, and decreased appetite. He was not tolerating an increase in the volume of his formula either, and he was deemed failure to thrive. Due to his worsening GI symptoms, the decision was made to proceed with immunologic workup. GI and ID also got involved this time. He had an endoscopy and colonoscopy, and a suction rectal biopsy was also done, even though there was a low suspicion for Hirschsprung disease, and it was normal. The colonoscopy biopsy report was positive for active colitis and proctitis with ulceration and marked reactive and regenerative mucosal changes. He was started on standard treatment for IBD with prednisolone and sulfasalazine, and he remained on Elecare formula with no solid foods. So I'll pause here for some differential diagnoses.
If anyone like to put in the chat some differentials for very early onset IBD? Kate, you might be mentioned in the next slide. So I see some XIAP, MVK, IPEX, very good. IL-10 receptor, CGD, excellent. NLRC4, CTLA4. Okay, this is LRBA. Feel free to keep adding. Okay, so we can go to the next slide.
Okay, so that was a great start. Right here, I have a table here that was actually published in 2019 by Dr. Kathleen Sullivan. Remember that about 20% of patients with very early onset IBD diagnosed at 6 years or younger are going to have a monogenic etiology consistent with an inborn error of immunity. And a lot of what was listed in the chat I see on this table. So moving forward, functional immunologic workup included IgG, IgM, IgA, which at diagnosis in 2019, as well as pre-transplant in our patient in 2020, were all within normal limits. IgE was normal as well. And at the time of diagnosis, neutrophil oxidative burst assay, newborn screening, CH50, C3, and C4 were also all within normal limits and ranges. So we had a strong suspicion for Xiap deficiency. So Xiap flow cytometry was performed, which showed absence of Xiap protein in lymphocytes. Genetic testing was done at 10 months of age. The commercial Sanger lab sequencing revealed a novel hemizygous variant in Xiap, where the A base pair was changed to G. And this mutation is an intronic mutation affecting the acceptor splice site in intron 3. So Xiap deficiency or X-linked lymphoproliferative syndrome type 2 is a rare disorder of immune dysregulation due to a defect in the Xiap gene, also known as the baculoviral IAP repeat containing protein 4 or BRC4. Xiap deficiency has historically been classified as X-linked lymphoproliferative XLP syndrome type 2. And the only curative treatment for Xiap deficiency is stem cell transplant, and allogenic HCT is sometimes indicated depending on the clinical severity. About 15% of all pediatric IBD cases are diagnosed during very early onset period, and only a small fraction of these patients have an identified monogenic cause. Defects in more than 50 genes have been reported to result in a monogenic form of very early onset IBD. So the BRC4 protein inhibits apoptosis by hindering pro-apoptotic caspases, particularly those for invariant natural killer T cells and mucosal-associated invariant T cells. Mutations in BRC4 associated with Xiap gene were first reported in 2006 to be linked with immune deficiency. There is dysregulation of TNFR signaling and NLRP3 inflammasome function. So without this protein, there's overproduction of pro-inflammatory cytokines IL-18 and IL-1 beta. This chronic state of inflammation leads to HLH, IBD, immunodeficiencies, autoimmunities, and lymphoproliferation. And patients are prone to recurrent HLH triggered by EBV, and IBD is very early onset and refractory. The first case of very early onset IBD secondary to a defect in this protein was reported in 2011. And in support of the link between Xiap and IBD, a study showed that among 96 male patients with pediatric onset Crohn's disease, 4 were found to have a deficiency in Xiap. So while a deficiency in Xiap protein can cause a severe form of very early onset IBD, only 17% of patients with Xiap deficiency develop IBD-like symptoms. So moving back to our patient, at 16 months, he underwent a 10 out of 10 matched unrelated donor stem cell transplant with fludarabine-based reduced intensity, reduced toxicity conditioning, including anti-thymocyte globulin, thiotepa, melphalan, and rituximab. He engrafted neutrophils on day 20 and was hospitalized for 6 weeks post-transplant. And his post-transplant course was complicated by sinusoidal obstructive syndrome with transaminitis. Total bilirubin was greater than 2. He had weight gain, and that prompted administration of defibrotide. He also developed an erythematous maculopapular rash that covered about 30% of his body surface area, which was consistent with grade 1 graft versus host disease. His course was also complicated by hypogammaglobulinemia and HHV6 viremia. And lastly, the patient had low donor chimerism despite multiple donor lymphocyte infusions. So at 22 months of age, our patient presented to the emergency room with a diffuse maculopapular rash and fever. He was also found to have conjunctivitis, a red tongue, peeling lips, swollen neck, and inguinal lymph nodes and loose stools. He had pancytopenia with persistent fevers for 10 days. At the time, he was not on immunosuppression and he had just finished a steroid course for GVHD. Blood cultures were positive for coagulase negative staph, stool cultures were positive for C. diff, and he was found to have positive antibodies for COVID 19. He was treated with IVIG and steroids and responded to treatment. Of note, the EBV PCR was also positive, and before it was negative. The numbers peaked a month after and then downtrended, but he remained positive months later. We hypothesized that the patient had atypical inflammatory syndrome that likely overlapped with both MISC and HLH. So here is a table comparing the clinical and laboratory data of our patient to that of MISC diagnostic criteria. As you can see, he met most all of the diagnostic criteria. In the COVID 19 variant, we likely think was the alpha variant given the time of exposure. And I've bolded all of the relevant labs that he had. Here's a table comparing HLH to MISC criteria. And as you can see, while there is a lot of overlap, our patient met most of the diagnostic criteria for MISC. Of note, he had impressive lymphadenopathy, leukopenia, and thrombocytopenia, as well as elevated pro-BNP in normal liver enzymes, which point to MISC. He also had rapid improvement with steroids and IVIG, which also point to MISC. His symptoms appeared 6 months post-transplant and about 4 weeks after COVID 19 exposure. In terms of his infection history, so pre-transplant, he had recurrent upper viral respiratory tract infections, including parainfluenza virus type 3 and non-COVID coronavirus, as well as acute otitis media. And post-transplant, he had recurrent C. diff, HHV6, viremia, human metapneumovirus, URIs, as well as enterovirus enteritis. So prior studies have shown that XIAP deficient patients have better long-term survival with reduced intensity conditioning transplants compared to myeloablative conditioning transplants. Reduced intensity, reduced toxicity regimen was used for our patient. These reduced intensity regimens are associated with reduced donor chimerism, as demonstrated in our patient as well. It's hypothesized that this reduced chimerism causes a persistently low level immune dysregulation, and this immune dysregulation becomes overactivated post COVID infection and leads to MISC or HLH. There is existing evidence that patients with XIAP deficiency have persistent immune dysregulation post transplant. So here I'll pause and pose a few questions. Was this really MISC or a mild HLH? Why isn't this risk ameliorated by transplant? Was low chimerism a risk factor for developing MISC? Could the low positive EBV titer be a contributing factor to the MISC? And should we continue doing reduced intensity, reduced toxicity myeloablative conditioning regimens for XIAP deficient patients?
Some people in the chat are talking about if cytokines were done when this patient was sick. They were not. I also would have really loved to see cytokines and fully look through the chart, but unfortunately, we're not done. Some people comment how the IL-18 level would have helped kind of distinguish it. If anyone like to comment about kind of if the risk is ameliorated by transplant in patients with XIAP for developing HLH? Also, maybe if Rebecca, if you'd like to kind of chime in about this low chimerism for the patient.
Yeah, so with a donor chimerism of 7%, you can expect that you're going to have disease recurrence. So you're going to be at risk of hyperinflammation. And with a total donor chimerism of 7%, I'm presuming the myeloid is probably even a little bit lower. But either way, this patient's going to be at risk for XIP deficiency associated problems.
And what do you think about the EBV titer?
I think it's so low, it's just reactivation in the setting of being sick. I don't think that that's contributing much.
You think it was more of the COVID?
Yeah.
And would you like to also talk about your experience using reduced intensity myeloablative conditioning regimens for XIP patients?
Yeah, so I will say a few words about this and not take up too much time. So, for patients with XIP deficiency, they have a couple of high risk factors. So, number one, they don't do good with myeloablative conditioning, and whether that's because XIP is an inhibitor of apoptosis and they just don't handle conditioning as well as they should otherwise as a factor is a little bit hard to delineate, but they are definitely prone to more inflammation going through transplant. And there's actually two mouse papers showing that recipient XIP deficiency drives more and worse graft versus host disease and increased mortality. And that holds up in patients too. Danny Arnold, who was at CHOP and was a fellow with us for a year and is now at the NIH, published a series of 40 patients, and they all got reduced intensity or reduced toxicity types of transplant prep. So things like Campath, Flumelth, Iotepa, things like reduced toxicity busulfan fludarabine or triosulfan fludarabine, and survival in patients without graft versus host disease was more than 90%. But as soon as you start to develop graft versus host disease, and especially obviously grades 3 and 4 GVHD, survival is much more poor, as low as 20% in the higher grades of graft versus host disease. And so both of those factors make transplant a little tricky. And so you definitely don't want to be doing fully myeloablative approaches in these patients. You also don't want to be going too light. We used to do a lot of just Campath, fludarabine, melphalan for patients with HLH because the overall survival was so much better than historic survival. But what you see is that you end up with about 40% chance of late graft insufficiency, basically. You get a lot of mixed chimerism and slowly over time have secondary graft failure because you don't sustain levels of donor chimerism that are sufficient to prevent disease. And XIP is different than the other causes of HLH, like the familial HLH disorders. And those disorders, you really care about your T cell chimerism because that's where the defect is in your T cells and your NK cells. You have a cytotoxicity defect. But in XIP deficiency, you really care about your myeloid cells because those are the cells that are having overactive inflammasome function. And so you're getting a lot of IL-1 beta production, IL-18 production from those cells, also probably increased necroptosis and other issues. And so an XIP deficiency, we really want to watch that myeloid chimerism. And we've had patients with XIP deficiency that actually will relapse disease manifestations at higher levels of donor chimerism than you might have expected based on historic experience with other HLH disorders. So 30-40% sometimes. And the IL-18, several people piped up about the IL-18 in the chat. That's a really good marker for these patients with mixed chimerism after transplant because at some level, if they're having sustained elevated levels of IL-18, that's a good indication that they may be at risk.
And what cutoff values would you use for IL-18? Are we talking 100,000, 50,000?
Not in the post-transplant setting. So if you have a patient with rip-roaring HLH in the setting of XIP deficiency, yes, your IL-18 is going to be 60,000, 80,000, this kind of stuff, 100,000. But post-transplant, that's going to normalize after transplant, and long term in the patients with mixed chimerism, they may have levels that are just 2,000, 2,500, this kind of range, that they may start to then develop some inflammatory manifestations, but not like a rip roaring HLH patient when it's going to be super, super high. And even the patients, when they're well, they may sit at 1,500, 2,000, 3,000, just being, not having any symptoms.
Okay, thank you. To make a couple comments from the chat. So, Sadiq pointed out an article published by Janet Chow up in Boston, looking at patients with MISC and then going back and doing whole exome sequencing. And two of those patients were found to have XIAP deficiency. They were diagnosed with MISC and they had no infections, but were diagnosed with XIAP. So, thank you for everyone should check out that paper. It's great. And then Leo Lynn had a question. Do XIAP deficient patients getting stronger conditioning regimens have a higher donor engraftment percentage post-transplant? I'll defer to Rebecca for that question.
Yeah, so in general, that's sort of the rule. The stronger your conditioning, the better chances you are to have, sustained high levels of donor chimerism. That's not always the case. You can certainly have either acute rejection or mixed chimerism with myeloablative preparative regimens, but fully myeloablative preparative regimens, the risk is much, much lower. But again, you have to weigh that risk with your patient population. And in patients like this that are prone to a lot of inflammation and VOD and pneumonitis and things like this, fully myeloablative regimens are really not the way to go. So something reduced toxicity flavor like a Buflu or Campaflu, Thiotepa, things like this are usually what people are using. Triosulfan.
Okay, thank you. And then Hamid pointed out that there may be more than just immune dysfunction in MISC in patients with poor mucosal barrier integrity, like in this patient, of course, who has early onset IBD, because of the hypothesis of the spikemia due to viral persistence in the GI tissues. I mean, if you have a paper that you'd like to link for others to read, that would be great. And Sneha had a question about using anti-IL-18 therapy, if you could get it in a patient like this, like this and done in LRC4.
Yeah, the trial's actually open for both. So patients with NLRC4 mutations or with XIP deficiency can enroll in the Todorganic alpha study. And you can enroll after transplant, actually, if you have, low levels of donor chimerism and have displayed that you've developed a complication of XIP deficiency and meet enough of the criteria.
Okay, great. I'm going to let Shreena move on. We've a lot of talk about IL-18, and we do have an IL-18 level coming up that was done post-transplant.
Yes, so currently our patient's donor chimerism dipped as low as 7% before donor lymphocyte infusions, and then it improved with DLI, but again downtrended to 11% as of last. So there is concern for graft failure. He is now status post DLI, 4 cycles of DLI. Further management, including a CD34 stem cell boost or a fifth DLI with a higher stem cell dose, is being considered. And a second allogenic HCT is also being considered. The IL-18 level on the most recent labs was markedly elevated. And here's also...
And I'll just say a word about DLI in this setting. I would just caution, we used to do lots of DLIs in patients with HLH or other immune deficiencies that we used reduced intensity campaflumelin, and it can be effective, but you do have a risk of graft versus host disease. And especially in a patient with XIP deficiency, you've tried, and so you're going to be escalating doses, but you're really going to run into a lot of risk for graft versus host disease, and it's not going to be very well tolerated. I actually had a sibling doing perfectly well after transplant, and then after a single DLI from a sibling donor, just developed horrible grade 4 graft versus host disease and died. And so we really have a lot of caution now for those reasons about DLI. So just a word of caution there.
So many studies demonstrate that MISC and HLH might occur due to a defect in the innate immune system affecting the interferon pathway. Xiap deficiency likely puts patients at risk for MISC and HLH due to the inborn error in innate immunity. Transplant may not mitigate that risk as there is likely a persistent low level of immune dysregulation that is still present post-transplant. And COVID-19 might activate EBV infection in this vulnerable post-transplant population. So COVID-19 vaccination and monoclonal antibody infusions, if infected, or as prophylaxis, are important considerations in these patients. And I'd like to also pose the question, what would be your threshold for pursuing second transplant for this patient?
And as a follow-up question to that, Oscar, what would you do in the meantime while holding over for a second transplant? What type of medications or immune modulators could you do? Rebecca, would you like to weigh in on this?
We're trying to leave it open for other people. So threshold for a second transplant. So this case is tricky, right? So we were talking a little bit before the webinar actually started. And, obviously curative therapy is going to be transplant. And so ideally, like this is what you would do, right? But it's difficult. And especially since this kid already had VOD, has already been through the ringer, I'm sure there are a lot of anxious, both physicians and parents about pursuing second transplant. And then what kind of conditioning are you going to use? Because you already went around, with campaflumab thiotepa. And so you can certainly consider second transplant because that's going to be, again, your option for curative treatment. And you might go with, a very targeted busulfan fludarabine regimen. You might do some prophylactic defibrotide going through transplant would be a good idea in someone very high risk like this that's already had VOD. You might also just give this some time for, a patient to more fully recover, have some time off, spend some time at home like this. And you might consider just putting them back on some chronic either infliximab or other anti-TNF or potentially anakinra or canakinumab, potentially enrolling in like the tautokinig alpha study, this type of thing, just trying some chronic immune suppression geared towards patients with Xiap deficiency and just seeing where that gets you. And this child, could potentially do well for a few years or many years. You never know until you try. Now, if you start running into, refractory horrible IBD and bleeding and, la, 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 you're going to be kind of more stuck. But I don't think there's a right or wrong answer here. And usually between the parents and physicians taking care of the patient, the right treatment course is sort of decided on together.
Thank you
And
for
Kate
that.
makes a good point that tautokinig is very well tolerated. It is because it's basically just a recombinant human IL-18 binding protein. So it's something that your body makes anyway. So you're just giving lots more of it. And so we've observed the same. It's extremely well tolerated. Generally, so are things like anakinra.
Scott Canna is putting a vote towards ruxolitinib. Okay,
It's
great.
easy.
Shreena, you could move on. And maybe you can put in the chat if anyone else has any other comments. Sorry, I cut you off, Rebecca.
No,
So-
cut me off. We got to move on.
I just want to acknowledge and thank the wonderful team taking care of our patient, and thank you everyone for the discussion.
Okay. Great job, Shreena. I'm going to pass over to Harry to moderate the next talk.
Hello, good evening, everyone. My name is Harry Lasman. I'm one of the assistant professor in pediatrics and molecular medicine at Cleveland Clinic Children's Hospital. I am joined by one of our allergy immunology fellow, Dr. Sarah Johnsons, and we are lucky here to have Dr. Julie Saba and Dr. Leon Carnes that serve as a local mentor here in discussing about these interesting patients of ours. And I will let Dr. Johnson to lead the presentation, and I will monitor the chat and then I'll stop if there are pressing questions that need to be addressed. And I will also encourage everyone to obviously keep putting their questions on the chat. And Dr. Saba, please feel free to chime in if you have any specific comments on part of the during the presentation itself. So go ahead, Sarah.
Thank you, Dr. Lesmana. So thank you for the opportunity to be able to give this presentation. So my presentation is entitled Abnormal Newborn Screen in Infant with Nephrotic Syndrome. So first, for the patient presentation, so we have a 9-month-old male with ichthyosis who presented to the emergency department with generalized edema, decreased oral intake, and voice changes. He was found to have an acute kidney injury with proteinuria and hyperkalemia, so he was admitted to the ICU. He was pretty sick. He was intubated due to respiratory failure, and he was placed on continuous renal replacement due to end-stage renal disease. And he was found to have an absolute lymphocyte count of 550, which prompted an immunology consult, so we got involved. As far as past medical history, he was born full term in California. He did have an abnormal newborn screen, which showed abnormal TREX. Repeat testing showed low T cells. He ended up getting mitogen's lymphocyte proliferation test, which showed just mildly low viable lymphocytes at day 0 at 70.3 with a normal cutoff greater than 75, but the PHA was normal. So he was evaluated by the Immunology department in California at 4 months, and since he hadn't had any infections, he was told to follow up at 8 months and to avoid all live vaccines in the meantime. As far as infection history since then, he only had oral thrush when he was 8 months old, which resolved with nystatin, and he had no viral or bacterial infections. His development was normal, and as far as his growth, he was the 22nd percentile for weight, less than 1st percentile for length, and the 4th percentile for head circumference. He was up to date on his immunizations, but deferred the rotavirus as the recommendations of no live vaccines. As far as family history, there was a great uncle who died of infancy from unknown cause, and a maternal great aunt that had leukocytosis, but no other notable immunodeficiencies in the family. And then socially, they had just recently moved to Ohio to be closer to family. So we got some labs. So first is the flow cytometry. So as you can see, there's decreased CD4 and CD8 T cells with normal NK and CD19 B cells for age. CD45 RARO showed decreased proportion of naive CD4 T cells. As you can see there, HIV was non-reactive. We did get immunoglobulins. IgG was low at 101. We did talk about that with his nephrotic syndrome, that he could be losing immunoglobulins that way, but we also wanted to look further at the B cell function, so we got some additional labs. So his titers overall looked good. He had 13 of 23 protective pneumococcal titers, greater than 1.3, and then he had some protection to all of them. And then his diphtheria and tetanus titers were also normal. B cell phenotyping showed a moderate decrease in the percentage of total memory B cells and switched memory B cells. And there was also a moderate decrease in the percentage of plasmoblasts as well. We repeated the mitogen stimulation, and it was completely normal for all of the tests. And then some additional labs, just since he came in for the renal failure, his creatinine was elevated, the potassium was high, he had low protein and albumin, and then he had 3+ protein in his urine. So as far as treatment, just while we were trying to figure out what was going on with him, he was started on prophylactic trimethoprim sulfa, and fluconazole due to his CD4 count being 187. We initially didn't start him on IVIG, but he developed a fever and became clinically unstable, so we did give him a dose of IVIG. With that kind of fever and instability, he didn't end up having a bacterial infection with all the cultures that were done, and then no viruses as well for that. So here's just a little summary statement for him, but I wanted to open it up to the crowd on thoughts of diagnosis and additional testing for this little one.
Thank you, Sarah. So just to summarize again, so this is a 9-month-old male with congenital ichthyosis, found to have nephrotic syndrome, and additionally was found to have lymphopenia, primarily affecting the T cells, and also some reduction in the switch memory B cells, although some functional lymphocyte T cell function is pretty adequate at this point, and then the B cell compartment seems, despite having some low switch memory B cells, there's adequate vaccine response showing some adequate function of this humoral immunity. So I'll see a couple of people. Was he getting peritoneal dialysis for his end-stage renal disease?
No, he was on continuous renal replacement, CRRT.
Yeah, so he was initially on CRRT. Since I know these patients as well, he's now transitioned to peritoneal dialysis, but he was on CRRT for a while. So a couple of other differential diagnoses that people have brought up include Simke immunoosseous dysplasia, Netherton syndromes. There's suggestion about doing NK cell function. Svetlana mentioned about MHC class 2 deficiency. Kit Sullivan mentioned about SGPL1 and Simke as well. Dr. Amit Rawat asked questions about if memory B cells would be reduced at 9 months, or was it abnormal for age? Can you comment on that, Sarah?
Yes, it was abnormal for age based on the levels for our lab, how they reported it.
And then Jack asked about the severity of his ichthyosis.
Yeah, it was severe enough where he had actually seen dermatology in California for it, and he was on a like emollients for his skin.
Okay, there are 2 votes for SGPL1 and split syndrome. Additional dysmorphic features on this baby?
Nothing notable, no, as far as dysmorphic features.
Okay. Perfect. So there are more votes for SGPL1. So that seems like the most voted diagnosis. Would you like to continue, Sarah?
I would, thank you. All right, so like many people in the chat said, we ended up getting whole exome sequencing, and it did show 2 causative variants for SGPL1. So I'm just going to do a little bit on this. So SGPL1, or sphingosine phosphate lyase 1. So this is the final enzyme in the sphingolipid degradative pathway. So as you can see on the right, circled in blue, that's the SPL. And just looking at this, I want you guys to focus on the S1P, which is right above it, as I go to my next slide, because that's what the SPL is breaking down. So why is this important in the field of immunology? So if we look at the T cells at the bottom in the thymic cortex on the left side, so as they're trying to migrate into the blood, so they go, and you can see the S1P in red and the T cells will have interaction with that and then will go into the bloodstream. And so it's important to have a gradient of the S1P where it's low in the thymus and it's higher in the bloodstream. And so that's why this is important to have the breakdown of the sphingosine phosphate lyase so that it can have this gradient so that T cells can migrate. And then on the right side, we see the lymph node. And so when we don't have the SPL, as you can see on the right side with the blue X, there's a lot of downstream effects. We know that there's lymphopenia, and there's a lot of other things as well that are going on. So as far as clinical features for these patients, so this was a paper showing that there's 46 children with this that were looked at. 37 of them had the steroid-resistant nephrotic syndrome. Many also had the primary adrenal insufficiency at 31, and then immunodeficiency was also the next most common at 31 out of 46. These children also have other problems with their endocrine system, neurologic problems, sensorineural hearing loss, and then also the skin problems as well. Kind of an interesting tidbit is that in 2017, next generation sequencing, led by two different groups, one located in the United States and one located in the United Kingdom, had a similar discovery of this rare inborn error of metabolism. But with the United States group, their cohort had the more focus of the nephrotic syndrome, and in the United Kingdom had more the focus of the adrenal insufficiency, which I thought was interesting. So as far as our patient, we know that he had the steroid-resistant nephrotic syndrome. As far as his endocrine system, an ACTH stimulation test showed partial adrenal insufficiency. Thyroid studies showed hypothyroidism. And then I went over the immunodeficiency standpoint for him. And then as far as neurologic abnormalities, he had an abnormal hearing test, which did show sensorineural hearing loss. Unfortunately, while he was in the hospital, he ended up having some developmental delays after he was extubated. He was found to have some speech delays. Brain MRI showed some volume loss, and then he had the skin findings as well. So here's a graph looking at prognosis. So on the bottom is age of diagnosis of either the adrenal insufficiency or the nephrotic syndrome. And then on the left side is years of life after diagnosis. And as you can see, the earlier the diagnosis is, the shorter prognosis patients have, unfortunately. So next, this leads me into talking about potential treatments for these children. So as you can see, that B6 is a cofactor for SPL. And it's also interesting that it's also an independent of its catalytic role. It can also function as a chaperone, and it can facilitate proper folding and stability of some mutant forms of the PLP enzyme. So that leads us to me talking about a couple of studies. So the first one is a vitamin B6 pilot study. So this was with 4 patients with this, and they had at least one missense SPL mutation. They were given vitamin B6 supplementation, and their absolute lymphocyte counts were monitored. 2 of the patients, one was homozygous for that mutation, and then the other was heterozygous for 2 different mutations, was compound heterozygous for 2 different mutations, and they responded with an increased absolute lymphocyte count. And a CD3, CD4, and CD8 T cell counts, and one of the patients had also improved. An S1P measured in the heterozygous patient decreased during the B6 treatment. And then, unfortunately, in the other 2 patients with these different mutations did not respond. To follow up on that study, they took the skin fibroblasts of those 4 patients, and cellular sphingolipid levels were obtained when the cells were in the absence or presence of vitamin B6. And the results show that the 2 skin fibroblast cells from the patients who were responsive to B6 showed reduction in the sphingolipids and an increase in SPL enzyme activity, while the 2 who did not respond also did not have response with the skin fibroblasts as well. So this suggests that some missense mutations may be responsive to the vitamin B6 supplementation. And then the third study is a mouse model of SPL insufficiency that showed having only 10 to 20% of normal SPL activity were lymphopenic, but otherwise they were healthy and didn't develop the severe sequela. So the next thought of treatment as well is gene therapy. So there is one study of adeno-associated virus 9 mediated transfer of the human SGPL1, and this was given to newborn mice, and typically these mice would die after the first week of life. And so they showed that treatment prolonged survival and prevented nephrosis, anemia, developmental delays, and high cholesterol, and the sphingolipids in the plasma and tissue were reduced compared to untreated mice. And the SGPL1 expression was measurable for at least 40 weeks. So kind of comparing these treatments, so as far as vitamin B6, there's definitely some patients who would be responsive versus not, depending on what their mutations are. But overall, the risks are pretty benign. The major side effect would be peripheral neuropathy. As far as the gene therapy, it's still in the early stages of development with only a mouse model at this point, but it could be promising. Other thoughts for treatment could be enzyme replacement therapy, gene editing, bone marrow transplant, or receptor targeting, but there haven't been any additional studies with those. So going back to our patient, so our patient had a mutation with one of them being at the Y416C. And going back to the papers, one of the patients who was responsive to vitamin B6 was a compound heterozygous with one of the mutations being the Y416C. So we're not sure which one it could be, but there is a chance that it could be responsive. So we ended up starting him on vitamin B6 therapy at 5 milligrams per kilogram per day. As far as other treatment for our patient, so he ended up being transitioned from the continuous dialysis to peritoneal dialysis. And then he's planning to have a kidney transplant when he gets a little bit bigger at 18 months. For his adrenal insufficiency, we're planning to give him stress steroids as needed, and then he was started on levothyroxine for his hypothyroidism. As far as his immunodeficiency, I saw him actually just in clinic 2 weeks ago, and his lymphocyte count hadn't improved yet, but he had only been on the vitamin B6 for about a month and a half. He wasn't having any side effects, so I ended up titrating him to 10 milligrams per kilogram per day, and we'll continue to monitor his absolute lymphocyte count. 1 month after he had gotten the IVIG, his IgG level was 298, and then another month later, it was 201. So since he hadn't been having recurrent infections, we decided that we would just continue to monitor and then see if he requires immunoglobulin replacement in the future. And he was continued on the antimicrobial prophylaxis, and was told to continue to avoid live vaccines at this time. As far as his hearing loss, he was referred to get hearing aids, and then he was sent to a developmental pediatrician along with therapies to help with his developmental delay. Dermatology was still following for his skin condition. And then the other thing that kind of came up with his hospitalization was he had failure to thrive, so a G-tube was placed, and they're continuing to watch his weight very closely. So we will have to see if he's one of the patients who is responsive to the vitamin B6 and how his further clinical course goes. I'll see him in another couple weeks for follow-up. So here are my references, and I just wanted to say thank you for listening, and I'll hand it over.
Thank you, Sarah, for the great presentation. And I will invite Dr. Julie Saba to kind of comment about this case. This is such a unique and still considered as a rare condition. So we are talking about the intersection between inborn error of immunity and inborn error of metabolism. So this is the underlying problem is, it's an inborn error of metabolism due to the defects in the enzymatic processes that led to the development of immunodeficiency in these patients. To my knowledge, this was diagnosed, I think discovered in 2017. How many patients we have had so far with this condition, Dr. Saba?
Right now we know of 64 patients, and that has gone up quite a bit from the first about 30 patients that were described in the first year after our papers were published. The back-to-back JCI papers together had about 20 patients altogether, and then several more papers came shortly after that. But now we're up to about 64. So, but that's worldwide. So it's a very ultra rare disease. And I just want to say, first of all, I want to say thank you to Harry and Sarah for inviting me to share on this presentation. It was an excellent presentation. And I'm also absolutely thrilled that so many of the listeners actually came up with the diagnosis. That means that our work is getting done and people are paying attention. Someone asked about whether the Invitae primary immunodeficiency panel includes SGPL1, and I had to fight for many months to get that to be a yes, and now it is included. It's not on every diagnostic panel, but Invitae does have it on both their nephrotic syndrome panel, their Charcot-Marie tooth neuropathy panel, and their primary immunodeficiency panel.
And how common do we have patients identified with abnormal newborn screening for due to abnormal TRAC levels?
So right now, I only know of 3 or 4 patients who've had abnormal TRACs, but my guess is that this is going to be very common. Most of the patients have a quite severe T-cell lymphopenia, but your case is very very similar to the kind of standard cases that we've seen where the patients may have an abnormal or even a completely absent TRAC at birth, and yet they have T-cell function. And that's based on the reason why they're lymphopenic is, as Sarah mentioned, is that this is a lymphocyte trafficking and egress defect. Someone mentioned that they were confused about or unclear about the gradient issue, the gradient theory. Basically, the S1P lyase is needed to reduce the levels of S1P in the thymus. The levels are high in the blood, but really it's a microgradient that's very, very close to the corticomedullary junction, right where the T cells jump out of the parenchyma of the thymus and into the bloodstream and become part of the immune system. That localized gradient is created. We showed a number of years ago that it was actually created by dendritic cells. This is a transplantable phenotype because the dendritic cells, rather than the thymic parenchyma, even though there's tons of S1P lyase in the thymus itself, we were surprised to find that the very rare dendritic cells that are present in the thymus are making that gradient possible. They carry the enzyme that creates this gradient. So the T cells, if they do get out, the escapers that get out are generally functional. It's just that they have such a low level because they have such a hard time getting out. And that's because they need to see that gradient.
So before I continue asking a question, there's some question from the audience asking would it be right to classify this condition as mitochondriopathy? Would it be possible to do some functional testing, such as mitochondrial membrane potentials? Do you think this is more in that area or conditions?
There's a lot of cellular and physiologic studies trying to understand the pathophysiology of this disease. There probably is some role for mitochondrial dysfunction, but it's very, very complex because this enzyme, it breaks down sphingosine phosphate, and that molecule is involved in lymphocyte trafficking through receptor-mediated signaling. So when the enzyme isn't working, S1P accumulates and you can get aberrant S1P signaling. But you also get accumulation of upstream sphingolipid intermediates because this is a metabolic defect. And many of those molecules like ceramide can be pro-apoptotic. They can be involved in autophagy. And so there are a lot of cellular effects. We are studying this enzyme in fruit flies and have seen really drastic changes in intracellular trafficking. So there are a lot of, and then there are products of the reaction in which the S1P is broken down, and a long-chain aldehyde and ethanolamine phosphate are produced. And the ethanolamine phosphate is also important in autophagy and probably lysosomal functioning. And so there's so many different biochemical levels at which there are problems, and they influence many different parts of the cell biology. So that's a long answer to, and the answer is maybe, but it's pretty complicated.
And then just to comment about the hypogammaglobulinemia, I think part of it could be because of the losses through nephrotic losses through the renal dysfunction. But can you comment about the humoral compartment itself? Based on your prior studies or any prior cases, do we see defects in humoral function, immune function in this patient in general? Because we did see in our patient there's seems to have some abnormal differentiation of the B cells. Do we see that kind of process is affected by the SPLIS1 as well?
So there is a range, and just like there is a phenotypic range in terms of patient symptoms and severity and age at presentation, there's a wide range of presentations immunologically. Not even every patient with SPLIS has T-cell lymphopenia. Even if you look carefully at the CD4 and CD8 levels and CD3 levels, they may be completely normal. Now, my suspicion is that if you looked at the CD45 RA-RO ratio and you actually looked at, or if you did TREC measurements and you actually looked at recent thymic emigrants, that you would find every patient with SPLIS has that abnormality, but most people don't do those studies. So some of the patients have very, very mild disease. Most of the patients just have low CD4 and CD8 levels and still have some function, reasonable T-cell function. But then there are patients who have low B cells, low NK cells, hypogammaglobulinemia, and not necessarily due to nephrotic syndrome, although in this case you can't rule out the role of the protein losses in the urine. So it can be quite variable. And so I wouldn't make the immediate assumption on any of these cases that they're completely fine. And I think the kind of reasonable approach that has been taken with this patient to give IVIG if they have symptoms and to avoid live vaccinations and such, that's pretty reasonable. So the other thing I'll just mention is that since people seem to know about SPLIS, which I think is fantastic, but before starting any kind of vitamin B6 therapy or doing a bone marrow transplant, please, I'm just making a plea to call me because we would very much like to measure the sphingolipids before treatment as well as after treatment, because we need to rely on biomarkers to be able to determine if the patient is responding to any intervention, because there's such a diversity of presentations that within patient biomarkers is probably going to be extremely important in clinical trials.
Thank you, Dr. Saba. I think we are at the top of the hours right now. It's 9 o'clock. And thank you so much, everyone, for attending our meeting today. And again, the second case, more illustrating, rare disease. And again, February is a month of rare disease. So we are trying to raise awareness of many rare diseases, including this new novel primary immunodeficiency syndromes, and I think it's great to have someone who's dedicating their life in studying such an ultra rare condition, and I think some of our patients deserve better answers and better care as well. So thank you everyone for attending, and I'll see you guys every next month.